Welcome, everyone. So today we're going to be talking about taking early action against gynecologic cancers. Before we begin, I'd like to make a distinction between what is a screening test and what is a surveillance test. So in general, what we always say is that a screening test is for the general population, meaning that someone who is walking down the street, that's just considered someone who is in the general population. On the other hand, a surveillance test is really for someone who is at high risk, meaning that someone that we know has an increased risk for having a particular condition. So many of you may know about certain screening tests that are currently available. We know that for breast cancer, there are mammograms. We know that for cervical cancer, there are pap smears. And for colon cancers, there are colonoscopies. Here are the statistics with regards to some of the gynecologic cancers for 2020. In the year 2020, it is estimated that the number of new cases of cervical cancer we have will be over 13,000, and of those patients, over 4,000 patients will die from it. With regards to ovarian cancer, there will be close to 22,000 new cases, but close to 14,000 patients will die of the disease. Whereas uterine cancer, about 65,000 patients are diagnosed with uterine cancer, and approximately 12,000 patients will die of the disease. So when we talk about cervical cancer screening, we also know that there are certain recommendations that we have now, and these recommendations have changed even from the past 5-10 years. Currently, the United States Preventive Service Task Force recommends that for women between the ages of 21 to 29, it is recommended they have a pap smear every 3 years. And pap smears have really been used for over 40 years with regards to screening patients. However, the task force also makes note that for patients who are aged between 30 to 65, there are two options. One option is to still getting a pap smear every 3 years, or the other option is something called a co-testing. Co-testing is when you not only perform a pap smear, but you also do something called HPV testing out of the pap smear. So we know that in the past 10 years, we know that cervical cancer is highly associated with the human papilloma virus. There are certain viruses that are considered high risk, meaning that it puts someone at higher risk of developing cervical cancer. So for women between the ages of 30 to 65, if they do not want to have a pap smear every 3 years, they can undergo co-testing every 5 years instead. And both of these recommendations are widely accepted within the United States. On the other hand, ovarian and uterine cancer, there is no universal screening test offered to the general population. And this is one of the challenges that a lot of patients have, because they may go to their primary care doctor asking for some type of screening test, and technically there is no screening test for ovarian cancer or uterine cancer. However, we do know that for certain patients, there is a surveillance program that we can offer these women. And this is one that is something that a lot of clinicians and patients don't really know about. So when we talk about surveillance programs, I'd like to break it down into 3 components. The first is, who is the target population that should be involved in these surveillance programs? What are the components to a surveillance program? And finally, how frequent should we be performing these surveillance programs? So with regards to target population, we have looking at the lifetime risk for ovarian cancer. So this is a study that was back in 1994. And this is the time period where we did not have a lot of good understanding with regards to the genetics or the risk factors for ovarian cancer. This was more of a descriptive study, meaning that they asked patients about their family history. And what they noted back in 1994 was that in the general population, the risk of ovarian cancer was 1.8%. Yet in the study from the United States back in 1988, they noted that if you had one first-degree relative with ovarian cancer, a woman's lifetime risk of ovarian cancer was 6.5%. One first-degree relative was defined as either your mother or your sister. On the other hand, if your mother had ovarian cancer, your risk for ovarian cancer then increased to approximately 7.5%. In the UK, they did a study also in '93 that looked at, very similarly to the American study, but what they actually did was that they broke it down by the age when the mother developed ovarian cancer. And what they noted was that if your mother developed ovarian cancer before the age of 45, a woman's risk of ovarian cancer was 25%. Yet, if your mother had ovarian cancer between the ages of 45 to 54, your risk was 9.3%. And finally, if your mother had ovarian cancer greater than the age of 55, your risk was about 6%, which, once again, this still confirms that if you have a family history of ovarian cancer, it does increase your risk as compared to the general population. So this study back in '94, before even we had robust genetics, suggests that even by just getting a family history on patients, you will be able to identify those who are at higher risk for developing ovarian cancer. Now, with the more recent advances that we have in genetics, we know that there are currently two types of mutations that may put a person at increased risk for ovarian cancer. One is the BRCA1, which is the breast cancer gene 1, which means that this is if you developed a mutation in the breast cancer gene 1, your risk for ovarian cancer can be as high as 45%. Please note that inheriting a mutation for the BRCA1 gene can be inherited from either your mother or your father. There is another BRCA gene, which is the BRCA2 gene, which once again you can inherit from your mother or father. And with this gene, if you have a mutation, there's an increased risk of ovarian cancer of approximately 12%. So now with genetics, we know that there is a certain population of patients that if you have certain genetic markers, it will increase your risk compared to the general population. What we also know is that for women with ovarian cancer, only about 20 to 25% of the women will have a genetic risk, meaning carrying a mutation that causes ovarian cancer. Unfortunately, for a majority of women, anywhere from 75 to 80% of the women with ovarian cancer, there is no known risk for ovarian cancer. But we do know that certain patients will have a high risk, either based on family history or actually undergoing genetic testing. With regards to uterine cancer, it's a little different. There is a syndrome known as Lynch syndrome, which is the hereditary non-polyposis colon cancer. And in patients who are at risk for Lynch syndrome, you have an increased risk for uterine cancer anywhere from 30 to 70%. Your risk for ovarian cancer can be up to 14%, and your risk for colon cancer can be as high as 80%. So here is another instance where we have a target population where they have a risk factor based on a particular genetic reason for why they would be at a higher risk for developing ovarian cancer or uterine cancer. Now, for our target population, what we are very interested in is whether or not the patients are symptomatic. And the issue here is that with both uterine cancer and ovarian cancer, there are no definitive signs or symptoms for ovarian cancer or uterine cancer. Although patients with uterine cancer or ovarian cancer sometimes will have complaints of bloating, pelvic or abdominal pain, difficulty eating or feeling full very quickly, or irregular menses, such as having irregular vaginal bleeding. As you can see, all of these symptoms are very nonspecific, but these symptoms, if a patient has these symptoms for a prolonged period of time, such as 3 months or 6 months, these are symptoms that they should bring to their doctor or clinician to understand what else needs to be done for them. So now we are going to move towards the components of a surveillance program. And in general, I will say that there are 3 components of a surveillance program. The first one is ultrasonography, which is basically a fancy word for saying that it is a pelvic sonogram, and sometimes it's called a transvaginal sonogram. Another component of a surveillance program are tumor markers, which we'll talk about, and the possibility of doing biopsies. So when we look at pelvic ultrasounds or transvaginal ultrasounds, we typically, when we are performing them, we look at certain features. So for example, when you do an ultrasound, those features that are usually considered to be benign, meaning non-cancerous, if someone has an ovarian cyst, is that something, you have a cyst that is less than 5 centimeters, or it is considered simple. And I'll describe them in a minute what we mean by simple. On the other hand, there are some features on your ultrasound that may be more concerning, meaning that the mass or your ovarian cyst is greater than 5 centimeters. If there are complex features in it, meaning that it doesn't look very smooth, there are lumps and bumps in it. Complex cystic means that there are both solid and cystic components to it, or if there are any nodules. So as mentioned, this is an example of a simple ovarian cyst. If you'll notice here that this is the cyst, this is an area of where the ovary is, and you notice that this looks completely black in here. This is black because on ultrasound, this is where this is all fluid in this area. These dots here is just a measurement of this area, but this would be considered a simple looking appearing cyst, and the risk of this being concerning is very, very low. On the other hand, we see an ultrasound of something that is complex cystic. So it's called complex cystic because they have this solid appearing mass on this edge. So this is the solid area. And then you have the cystic area here, which is this area over here. So these are typically called complex cystic masses. This area here also is sometimes called a nodule or an excrescence. And so if there's features like this, it could be concerning. With that said, not all complex cystic masses are concerning for cancer, but that's where you need to know about the patient's family history and any other associated symptoms. And this is why when you have a pelvic ultrasound that's being performed for you, it many times is going to be helpful for someone to review these ultrasounds with you. Now, when we look at ultrasounds, and this was a study that was done back in 2005 by Fishman et al. What they did in this study was that they identified over 4,500 women who were high risk, meaning that these women were at increased risk for developing ovarian cancer. These women underwent over 12,000 ultrasounds based on the fact that they may have had symptoms, or these were based on screening for them. And from the over 12,000 ultrasounds that they did, 49 women underwent surgery because there was a persistent ovarian mass. And what they found in this study was that of the 49 women who underwent surgery, 12 women actually had developed, had cancer at the time of surgery. And what they also identified was that all 12 women who were found to have cancer were all with stage 3 cancer, meaning that these were cancers that had extended outside of the ovary already. So one of the arguments of why one would not perform, why ultrasounds are not good screening tests, is that you are doing a lot of ultrasounds and close to 100 women are actually undergoing surgery, but you only identify 12 women who had cancer. I mean, close to 50 women having surgery and 12 women actually identifying having cancer. So one of the arguments in these cases is whether or not this is appropriate screening test for patients and in this scenario. With regards to screening for uterine cancer, ultrasounds can also be done. However, for premenopausal women, meaning women before the age of 50 and those still having menstrual periods, it can be very challenging. And the reason why pelvic ultrasounds for premenopausal women can be very challenging is because the lining of the uterus will change with their menstrual cycle. So depending on where you are in your menstrual cycle, the lining can be thicker during a particular cycle. On the other hand, the use of ultrasound for postmenopausal women screening is a little bit easier. And the reason why it's considered easier is really because you can monitor the stripe or the lining of the uterus. And typically we will say that if double thickness, if your lining on both the front and the back wall of the uterus is less than 4 millimeters, then the likelihood of a cancer is very low. So this sometimes is used as a screening for some of our patients with uterine cancer. Tumor markers or serum markers is another type of surveillance that we have for patients. And one of the typical tumor markers that many folks hear about is something called the CA-125. And basically the CA-125 is a glycoprotein. It is a protein that is normally expressed on the ovary, the heart, the lungs, and the gastrointestinal tract. So it is found normally in the human body. But what we also know is that for women who have advanced ovarian cancer, advanced stage ovarian cancer, 80 to 90% of these women will have abnormal CA-125s. Yet, if you take women who have early stage ovarian cancer, for example, those where the cancer is just confined to the ovary and has not spread to other parts of the body, approximately 50% of those women will have a normal CA-125. So this is one of the limitations of a CA-125 in that it, like many other tumor markers, is not a perfect test. To make matters more complicated, there are many non-cancer conditions that can cause a CA-125 to be increased. So you don't need to have cancer to have an elevated CA-125. So for example, in just very typical, quote unquote, normal gynecologic conditions can have an elevated CA-125. Having an ovarian cyst, a benign non-cancerous ovarian cyst, can cause an elevated CA-125. When someone is having ovulation or menstruation, that can cause an elevated CA-125. Pregnancy can increase your CA-125, and fibroids, where you have a fibroid uterus, which is an overgrowth of the muscle of the uterus, can cause an elevated CA-125 also. At the same time, there are some types of inflammation that can also cause an elevated CA-125. So any type of inflammation in the chest, like pneumonia, inflammation around the heart can cause that, or in the GI system, such as the large bowel or the small bowel can cause an elevated CA-125. So it is not uncommon for a patient who may have a condition known as diverticulitis, which is an inflammatory condition of the intestines that can be seen in patients who are a bit older. And what we see is that when they have that inflammation, the CA-125 can be elevated, and that could raise concerns about cancer. But what really happens is that when you control that inflammation, the CA-125 goes back down to normal. So this is why a CA-125 has not been a perfect tumor marker for the general population, but more for the high-risk population. When we look at cancers that are associated with elevated CA-125, the elevated CA-125 does not tell you exactly one type of cancer. For example, cancers of the ovary or the uterus can have an elevated CA-125. At the same token, colon cancer and breast cancer, if it spreads to other parts of the body, can also cause an elevated CA-125. So when we're looking at CA-125 and cancers, it just tells you that there could be a cancer that is out there, but it doesn't give you the specific cancer. So when we look at our components of our surveillance program using the ultrasounds and your tumor markers, what I always say is that the combination of these two surveillance programs, your ultrasound and your serum markers, are actually going to be more meaningful. Many times it's very challenging to just use these in isolation from one another. And really, you just want more data points to help you make some decisions in how to manage patients. With regards to biopsies that are available, it should be noted that there are no biopsies for the ovary if you're worried about ovarian cancer, because biopsying the ovary can be very challenging technically, and it can be dangerous also in that sense. So usually for the ovaries, there is no biopsies that you could do in the office or in radiology for them. However, for uterine cancer, it's a little different. There is possibilities and ways of doing a endometrial sampling, meaning sampling the lining of the uterus to see whether or not there's cancer or pre-cancer conditions in there. Typically, you can do something in the office, and many patients tolerate it fairly well. The office biopsies are very similar to a pap smear, other than the fact that they put the catheter into the uterine cavity to do the scraping. For those patients who cannot tolerate an office biopsy, we do outpatient procedures such as a dilatation and curettage, other known as a DNC. These are outpatient procedures that many patients tolerate very well. It takes probably 30-40 minutes to do it under some type of anesthesia, and most patients will go home the same day after having the DNC done. So the next question is, when we have these surveillance programs, how often should you do these surveillance programs for patients? As we mentioned previously, in cervical cancer, in a screening test for cervical cancer, it is getting pap smears anywhere from every 3 to 5 years. With ovarian cancer, the surveillance program is very different. Most folks will agree that if you are known to carry a mutation on the BRCA1 or BRCA2 gene, then you should have a ultrasound and getting the blood work, the tumor markers, roughly every 6 months. This is something that in the Europeans and in the UK, that they actually do this for all of their patients who are known to be BRCA mutation carriers who do not undergo definitive surgery. On the other hand, for those patients who have not undergone genetic testing, but for those patients who have a very significant family history of ovarian cancer or breast cancer, we typically recommend that they get the ultrasounds done every 12 months. So really once a year to monitor the ovaries from there. As mentioned, getting ultrasounds can be challenging, especially for patients who are younger, because when you're younger, you can have ovarian cysts and lumps and bumps of the ovaries that are not concerning for any type of malignancy. As I mentioned before, getting your ultrasound or getting your tumor markers, any single result at one time frame is not going to be that helpful. And the reason for that is because it's just giving you information about one time frame. Unless that ultrasound, the blood work is very, very abnormal. What I tend to do is I tend to monitor or follow the trend of the ultrasound, meaning that if I see that a patient has an ovarian cyst, I will tend to follow that ovarian cyst in the next couple of months to see whether or not it's growing or is decreasing in size. Typically, what I'll tell patients is that if you have a cyst on your ovaries and in 2 or 3 months' time, the cyst goes away, I could say with a fair amount of confidence that that's not going to be cancer. Yet, on the other hand, if you have a cyst that continues to grow, then one would need to be concerned that it may be something that could be cancerous, or it could be normal physiology. The same thing with the CA-125. For patients with ovarian cancer, when we're monitoring the CA-125, if someone has an elevated CA-125, and that CA-125 without any surgery or chemotherapy goes back down to normal, many times we argue that that's a normal condition and that's normal physiology. But if your CA-125 continues to increase, it may imply that you still have an inflammatory condition, and that's why it's increasing, or it may imply that you have a underlying cancer. So it could still be benign or cancerous. And in those cases, we may then want to continue to pursue getting further testing in that scenario. With regards to uterine cancer, the question is, what do you do for uterine cancer with regards to surveillance? And typically the recommendation is that every 12 months, one should consider an ultrasound or an endometrial sampling. This is more for patients who are at higher risk for Lynch syndrome or who are known to be carriers of being in the Lynch syndrome family, who needs to have more surveillance with regards to their lining of the uterus. Now, as before, I had mentioned that we looked at how many new cases in 2020 we have of cervical cancer, ovarian cancer, and uterine cancer. And what we've noticed here is that with ovarian cancer, we noticed that even though there is only a little bit over 21,000 women who develop ovarian cancer, approximately 64% of these cases may actually, or women who have ovarian cancer will die of their cancer. So the question is, what do we do, and why is surveillance so important upfront, or screening tests? And the reason why it is important is really because it helps us identify, surveillance programs helps us identify pre-cancer conditions. So in cervical cancer, we have the dysplasia ahead of time that can be identified. And in ovarian cancer and in uterine cancer, we have pre-cancer conditions. And many times it is argued that if you identify a patient with a pre-cancer condition up front, what ends up happening is that if you take care of that pre-cancer condition, you may prevent the patient from developing cancer. So in some ways, the patient may be quote unquote cured of their underlying condition. So that's one of the reasons why surveillance programs or screening programs are so important. At the same token, with the surveillance programs and screening programs, they also help us identify patients at an earlier stage of cancer. And we also know that for every cancer condition that we have, the earlier the stage that we can identify the cancer, the better that we can actually treat these patients earlier, and they generally tend to have a better outcome. So in this study back in 2011, they had over 37,000 women who are asymptomatic who underwent annual ultrasounds. So these women, basically, they would just do ultrasounds for them, and because they were concerned with ovarian cancer, but they didn't really have any symptoms. What they found at the end of the day was that approximately 47% of the patients were found to have stage 1 disease ovarian cancer. And the reason why this study was so important is because if you are able to identify patients with stage 1 ovarian cancer, they actually have a better prognosis. And this is because in many cases with stage 1 ovarian cancer, if you just do surgery alone, these patients do not require any chemotherapy and they are cured. On the other hand, with ovarian cancer, if you identify patients as stage 3 or stage 4 ovarian cancer, these patients will invariably need to have surgery and chemotherapy, and these patients actually, their prognosis is not as good as patients with stage 1 ovarian cancer. So with regards to this, we have several take-home messages. It's important to keep in mind that for the general population, there is no effective screening test for ovarian cancer or for uterine cancer. There are certain very effective screening tests for cervical cancer, breast cancer, and colon cancer, but not for other types of cancers. But just because we don't have good screening tests for all cancers, what we need to do is identify a high-risk population. For those high-risk population, there may be those with uterine cancer or ovarian cancer. With these patients, what you would do is you would offer them a surveillance program, which would include ultrasounds, CA-125s, and the potential of biopsies. The other take-home message is that every patient really should be proactive, meaning that if you have persistent and worsening symptoms, you need to do something about it. And a lot of times, patients will call their providers to tell them about the symptoms, or sometimes patients will rationalize why they have these symptoms. But really, from my perspective, if you have a patient who for 3 months continues to have these symptoms, something needs to be done. The things that we talked about, such as getting an ultrasound or getting blood tests, are things that can be uncomfortable for patients, but really are not life-threatening procedures for the patients. So ultrasounds and blood work can be very safe for patients, as are office biopsies can also be very safe. So if you have these symptoms, then I would recommend that you connect with your provider to see what can be done for you so that if possible, we can identify these cancers at an earlier stage for patients. Thank you very much.